Last but not the least, let me invite Dr. Chen Zuchi from Taichung in Taiwan to share with us his case.
Okay, good morning, everyone, and thanks for your kind introduction. And I'm gonna share an interesting case. Is about the rail we overlook. So managing how sometimes we get lemon road ablation, but sometimes we get Burr entrap. So how do we manage it? So we know that okay, when we met the condition like rota entrap, the Burr entrap, sometimes if you cannot pull it out gently, maybe you need to cut the rota shaft and insert the guide extension catheter to give you best support to remove all the devices. But just remember, if you want to do this, you need to, after you cut the rotablator, you need to remove the outer sheath, because this outer sheath is around 4.3 French. So if you don't remove it out, you cannot use maybe 5.5 guide liner, because you need to use 7 French guiding catheter to insert this, and it's quite a bit harder. So just need to remove this outer sheath. But sometimes we can use this outer sheath for us to solve some problems. So, okay, it's a 87-year-old case with non-STEMI. So it's okay. It's a 87-year-old male with a past history of cardiovascular disease. He had done PCI before, and he received a DES in RCA. So this time he came for non-STEMI. So we checked this RCA. So you can see that the previous stent is in the mid part to distal part of the RCA, and it got a little bit of stenosis. But the tight lesion is in the proximal. It's a de novo lesion. So we fixed the lesion very quickly, just by balloon dilatation, then stenting. It's okay. Good. So this is the final RCA result. Okay, so let's get the previous LCA. So you can see that is lemon distal tight lesion. And with this diagnostic catheter is an AL2 diagnostic catheter. But I don't know why at that time. You can see that it's quite a tight lesion, but the operator didn't just leave it alone. I don't know why. Just leave it alone and he fixed the RCA. I don't know why. You can see that maybe in some view, maybe it's not that severe, but in the lateral, this LL cranial view is quite tight. You can see that it's concentric calcific lesions in this area. So it's 5 years before. So we can see the LAD is also got heavy calcified lesion to the mid part of the LAD. So at this time, I'm not just fix RCA, I'll try to fix LAD. So how do we fix LAD is so I try to use EBU, but the general EBU guiding catheter can just at this position. So I think it's very high position, high take of the left main. So I reuse the AL2 diagnostic catheter again. So you can see that the lesion is still there. Okay, so our target is the distal left main calcified lesion to mid part of the LAD. So I'm started to change the guiding catheter. So need to wait. Okay, so I use 300 centimeters C-on wire to go to the distal part of a LAD. It's still diagnostic catheter. So after wiring down, I pull out the diagnostic catheter and use the this 300 centimeter and 0.35-inch coil wire to assist the AL2 guiding caster. But as you can see that the guiding caster is quite firm, so it cannot easily manipulate. So the wire is like this. It's like this. So I cannot engage with this. So I turn to use EBU, guiding caster 4/7 French. So I try to use the 035 coil wire as a support. Gently manipulation, then I can redirection my guiding caster. As you can see like this. So I can use balloon to anchoring inside to get the best engage of the guiding caster. So as you can see, I use 2.0 and it can be cross the lesion. So after anchoring, guide extension caster can get engaged. So I will do the rotablation for this very tight lemon part. So it's difficult because you can see that it's I need to start with the rotablation from the guiding caster, and it's still very close to the lesion. So okay, so I want to do balloon angioplasty for the mid part, then DCB, then try to do rotablation for the proximal part, then put the DS to the the main. So it's not easy. So my challenge point is lemon rotablation, and it's quite close to guiding caster. So I set everything okay and choose 1.75 because I need to rotablate to the mid part of the LAD. Okay, so I started to do rotablation. So you can see that it's not easy to cross the tie lesion, but at some point it jump over. Then I can do the mid part of the rotablation. But because I think the ablation is not enough, so after the mid part of rotablation, I cannot move my burr out to the guiding caster. So it was stuck here. Okay, it's the mid part is okay. But when I want to move out the burr, it was stuck. Sorry, here. I was stuck here. So how would you do? In the if I can move it out gently, I don't need to cut that. But as you know that my guiding caster is so close to the burr, so I think I don't need to cut it. I just insert the guiding caster a little bit. Then you can see that. Insert it, then move it out together. Okay. Move it out together. Okay. It gets out. But I still need to do rotablation for this an ablated lemon part. So how do I do? So I just use this the dynamo, as you can see here. Just a little bit advanced with the dynamo. Then use the burr as assist. Insert a little bit. Then the wire is like this. So I need to a little bit advance my wire, then use dynamo, advance into lemon again. Okay, so as you remember that we have the outer sheath. So we can use this outer sheath as a support to re-engage our guiding caster. So you can see that it's 4.3 French. So you can see the guiding caster. Okay, can re-engage back into the main. Okay. Okay, so back again, we can do the rotablation again. So here's our re-engage technique is to use a dynamo to facilitate your burr re-engaging into your lemon. Then use the strength of the outer sheath, then re-rail, then advance your guiding caster. So back again, we can do again 1.75. since we pass again, so we can do it gently. And finally, we can do the polishing round. It's very smooth. So after that, we can do balloon dilatation, then stenting, then IVUS guide. We can jump to IVUS. We put 2 stent, the ultra thin stent, 2 to the osteolamine. Okay, and then post dilate to 5. And this is the final IVUS. You can check it. Our stent is landing in the quite well area. Okay. So maybe we can move it. Sorry. Okay, it's the stand and the part of the LED. Then you can see the circumflex comes out. With the LED seems like okay, expansion is okay, and apposition is good. Okay, so comes out, and it's the calcified part of the main. It seems like okay, MSA is okay, and stand almost to the proximal of the main. Okay, so this is the final result. Okay, with the DCB in the mid part of the LED. Okay. Okay, so I think. Oh, sorry, we can't have. Sorry. So I think the point of the case is use the long wire to exchange guiding catheter and do the roll ablation in the leg main, and try to use this Rota support salvage the entrap of the Burr, and using the ultra thin stent to cover all. So I think when you get a stock Burr, try to don't be panic, because we should check the antegrade flow is okay and vital signs okay. Like this patient, when we get the Burr stock, the flow is quite okay, so we can do all the things. So I think the Rota outer sheath, sometimes when we do remove the Burr, we need to remove the outer sheath first. But in this case, like this, we can use this to rerail your guide into this difficulty anatomy, like this very difficult leg main. Okay, thank you. And welcome to Taiwan's next interventional meeting. It's TAMIS in March 7 to 8. Thank you. Thank you.
Yes, thank you very much for a very excellent presentation and very great survey from the Burr entrapment in the left main. And I think that we had a lot of questions for this presentation, because we have to clear out that why the Burr entrap into the left main, and it's not very hard to take it out, because usually it is very hard to pull back the Burr from the system. So could you clear a little bit for us about why the Burr entrapment in this situation? Because if we don't know the mechanism underneath that, so we have to make the mistake again for another operator.
Okay.
Yeah.
I think the reason why this Burr stuck in the limb, it's not stuck. It just I push it too hard, because it's too close to the start point. So when I get when my Burr cannot advance, I try to push it, but I think the lesion is not ablate enough. So maybe I push too hard, then it just jump over. So I can do the rest of the Rota ablation in the mid part of the AD, but I can move it out. So I think it's due to the ablate is not enough.
Most of the Burr entrapment occurs because as you ablate the lesions in a particularly angulated or eccentric lesion, it goes out the greater curvature, and when you pull it back, it oftentimes come back on the lesser curvature, and that's how you get trapped and so forth. So you're fortunate because your guiding catheter is very close to the Burr, so that guiding catheter now acts as a fulcrum where you can just pull it back. But if your guiding catheter is far from the entrap catheter, I commonly now will do one thing. I don't cut anymore. I used to do that. I just need to pull back the wire, because the wire, the radial opaque, is always going to be larger than the Burr side. And now I have the guiding catheter and I pull back together. That becomes a fulcrum. It's much easier.
in that sense. No need to go and cut. Like I say, if you sometimes need a larger guiding catheter or extension catheter to bring down to that trap burr. The second comment I have here is that instead of using a long guide wire to exchange a guiding catheter, I know as a fellow in the past, we use a long 035 guide wire instead because it gives you a lot more support. You keep the guide wire in there, you take a 035 wire, long wire, and then you switch your guiding catheter, but it takes a lot of maneuver. The third options I would have done, I would just simply go to the femoral approach because if my radial is giving me so much trouble, I might as well go to an alternative access. And
This case is from femoral.
oh, it's from femoral.
With
Okay.
long sheath because it's also difficult in iliac artery. Yes.
My final comment here is that when you have a very calcified artery, I try not to use an ultra thin stents because I think there is a radial support issue for calcified lesion. Thanks.
Yes. Thank you.
Yes, Alaja.
Yes, excellent case. I have two comments. First of all, the exchange of the guiding. I actually also we learned a lot from Japanese master in the past, right? I think what I learned is trick. They're not using one long 300 centimeters guide wire. They use two. One of them can be a supportive wire, right? Like for example, Ironman 300 cc, and then you have two rails, and then negotiating the very stiff, the big guiding catheter is more easy instead of just using a 300 cm Xenon guide wire. Second, I guess the reason it gets stuck because of the angulation of your guidings, your left main, and the LED. There's also you can see there's a lot of angulation. So. And I'm not too sure whether in case, because it's a big vessel, right? In case using orbital atherectomy by means of pullback ablation may reduce this sort of stuck burr, right? But the overall thing is an excellent demonstration of how you retrieve the stuck burr.
Yeah, thank you. I agree with OA maybe solve this problem because you can go and back.
Pullback ablation.
Yes.
Yes, I would like to ask the rest of the panel, Professor Virat and Dr. Trisang, that how to prevent the dissection of the left main when we try to pull back the burr from the entrapment segment of the vessel, because I think in this room already have the operator get the complication with the left main by dissection after so much use like a manual like a technique in order to take the burr out. So we call it long dissection from the left main to the LED in this Ho Chi Minh City. So could you give us a little bit more about the technique in order to prevent that? Because it's, in that situation, usually we have to quickly remove the burr. We don't pay attention on the left main, so the left main dissect because the guide is sucking in. Professor Virat.
Yes, my routine practice for removing the stuck burrs, and I will retrieve the guiding first to let it stay far away from the ostium. So you have a space to exchange the guiding catheter with the device still stuck. And the other reason is that when you remove the guiding catheter, maybe it's change the angle of the catheter to the left main. In this case, Dr. Shen also pull back a little bit to rest up the to reduce the angle, so that you can enhance the force of pulling as well. And then when rotator stuck, try to pull everything out together, because the guide wire you cannot keep it in press. I think you have to remove together and then reinsert the wire later.
Yes.
I think that one of the techniques I used, I asked for my fellow, my junior doctor, that they use another wire in order to prevent the guide sucking in. Because the blockchain wire is very easy for it in order to prevent the sucking from the guide, but keep the guiding very close to the arch of the left main. So we still have a lot of support from the guide, and also away from the guide sucking in. That's the technique that I usually use, so I don't cause some more dissection because we already had the problem on the table already, so we don't want to make this a little bit more complicated.
Okay, thank you.
in this case, I see that the small balloon can cross. So because we see that it's very high risk for rota, so we can choose another. I think that's safer. For example, try to cut thin balloon or something, or we use the IVL. We change the way instead of use rota.
Thank you.
Do you think that another option, the balloon-based technique?
Yeah. It's also a good option, but but when we do the balloon dilatation with 2.0, at that point it cannot be fully dilated. So of course you can use IV or something, but you should make sure, because this area is the leg main. If you use IVO, you need to open it maybe for some time. So I think that's more difficult for this case. So I think past the rotablation or OA, I think it's easier for this case. Yeah, thank you.